Okay, welcome back, everyone. It's Dr. Linder. Now we're taking a look at the trunk or the torso. This is looking at it from the anterior trunk. And what we see here on the person's right side, right, anatomical position, we see Pec Major. Now, if there's a major, there's going to be a minor, but the minors are deep, meaning we have to dissect this away in order to see the minor. So Pec Major, we can see it originates right here along the sternum, and then it's going to insert on the bicipital groove or the intertubercular groove. So that's Pec Major. And when we see the way these fibers are, when this muscle contracts, it can rotate that upper limb this way. We call that internal rotation. But it can also adduct the arm. So it can adduct, it can ADD, it can adduct the arm, and it can also medially, that's so sloppy, let me see if I can erase that, medially rotate, medial rotation, medial rotation of the arm, medial rotation of the arm. Now, if you're ever asked actions on an exam, you can't just write flexion, extension, internal rotation. You have to put the part that it's moving. So if it asked Pec Major, you would say arm adduction, arm medial rotation. You have to put the part of the body it's moving, not just the action. If we dissect this away deep to it, attaching to ribs 3, 4, and 5 is Pec Minor. And it inserts right there on the coracoid process. Coracoid process of the scapula. That's why the bones are really important. You can't just forget the landmarks. I typically ask the parts that I know are going to come to haunt you again with muscles, whether they're origins or insertions. Okay, so now here's the head and the neck, and superficially, right, here's the clavicle. Here's the upper part of the traps that we can see here. On this side, there's your platysma. We'll put P for platysma. We'll put T for traps. Then here's Pec Major. Here's the sternal division. And then here's the clavicular division. So this is why when you see people training at the gym or exercising and they change the angle of how their back is when they're doing chest, they angle it differently to either target the sternal division or the clavicular division. But as a whole, Pec, and I'll put a capital M for Pec Major. Here's the anterior delts. Here on the side is the middle delts. And then on the posterior would be the posterior delts. Now on the left here, or this person's right side, or our reading left, we can see Pec Major. But if we dissect that away, here we have Pec Minor. And we'd see the insertion a whole lot better if we took the deltoids away. If we dissected that and pulled it away, we'd be able to see the coracoid process so much better right there, right? That would be the coracoid process of the scapula. Now, here are the ribs, and then we can see the intercostal muscles. We have the external intercostals. If we look at these fibers, they run this way. And then the internal intercostals run almost perpendicular to those. External, because they really are more external in relationship to the deeper internal intercostal. Intercostal means between the ribs. They're involving elevating and depressing the ribs during breathing. Okay, so you have an external and internal intercostal. The externals are like go in the direction of your forearms. If you were to put your hands in your pocket, the external intercostals go in that direction, like putting your hands in your front pocket. This is just showing the diaphragm. This is innervated by the phrenic nerve, which comes from C3 to C5. And Lindner's little rule is C3, 4, and 5 keep the diaphragm alive. C3, 4, and 5 keep the diaphragm alive. That's why when there's birth trauma or neck issues or challenges from delivery, they always check the baby's breathing to make sure that they're breathing and there's no sudden infant death syndrome going on, or SIDS death or crib death from traumatic birth, from really traumatic type of delivery with forceful traction of a baby's infant's cervical spine. They can damage the nerve endings or traction the spine, damaging the cervical region, C3, 4, and 5, which is where the phrenic nerve comes from. C3, 4, and 5 keep the diaphragm alive. And this is just looking at the diaphragm for underneath. In anatomy and physiology too, when we get into circulation, we will go and have to understand what the blood supply to the diaphragm is as well. Okay, so just wanted you to get used to the anterior and superior view, as well as what it looks like dome-shaped underneath. And you can see these holes here because the holes are necessary for major blood vessels and for the esophagus to travel through there. Let's look at the stomach now. So when we look at the stomach, we will see probably the most famous muscle, right? Because we see all these male models and female models trying to get all of their body fat down to nothing so that we can clearly see the 6-pack or the 8-pack, which is 1, 2, 3, 4 plus 4. If you have a 6-pack or an 8-pack, what we're looking at is the rectus abdominis muscles. And what separates each of them are these tendinous inscriptions, which are these that run horizontally. They're called tendinous inscriptions. The line that runs right through the center longitudinally or sagittally is called the linea alba. The linea alba. The other two muscles left are the internal and external obliques. Now, notice on this side, we can see the ribs, and on this side, we don't. So this is more superficial or external. So here's the external abdominal obliques. And again, if we look at those fibers, it's like putting your hands in your pocket in that direction, putting your hands in this direction, going into your front pocket. That's the external abdominal oblique. And then always the internal abdominal obliques are going to run perpendicular to that, okay? So the internal obliques would run deep, but they would run in this direction here. That would be the internal on this side, always perpendicular, okay? So the external on this side would run this way, and then the internal is running in the opposite direction, internal abdominal obliques, okay? In terms of action, let's see if I can. So when this one contracts, when the right, this is the right side. So when the right external abdominal oblique contracts, it's going to bring that right shoulder over to the left hip. And when the left internal, so they're going to work in the same direction, right? So the right external abdominal oblique and the left internal abdominal oblique both work to bring this right shoulder in that direction to the left hip, right? To create like left trunk rotation, I guess. But it's kind of like doing sit-ups, but not doing a sit-up perfectly in line with your body. It's doing the twisted ones, like in the old famous Rocky movies when he goes side to side to strengthen his obliques, both external and internal obliques. Now, if we take this torso, right, the abdominal torso, we take that and dissect it, and we look at it from the inside, from the other view. Now we're looking at muscles that run this way across transversely. So that's the transverse abdominis. Okay, we just spent the time looking at it from that view. On the anterior, this is now looking deep. Transverse abdominis. When we look at the posterior, let's see what we have. We've already covered this one. We did the levator scapula, Splenius Capitis, and Semispinalis Capitis. We said the only reason why we could see these three up here is because we dissected away the upper trapezius and the middle trapezius and the lower trapezius. If we dissect this away, which is superficial, it brings us to the left side where we can see those three neck muscles along with the rhomboid minor and rhomboid major. Okay. The widest muscle of the back is here. It's called the lats or the latissimus dorsi. Goes up like this. Okay. That's the latissimus dorsi. In alignment with the lats on the right-hand side, let me erase this a second. Right here, we have teres major. Now, teres major and the latissimus dorsi, you could see right here, they both go underneath the armpit and they'll attach to the front of the arm where the bicipital groove is. So both teres major and the lats attach to the anterior side of the arm. Even though we're looking at this from the posterior, it attaches to the anterior side of the arm on the bicipital groove. Okay. All right, the only other muscles here that I'd like for you to know, the Erector Spinae group. Right here, that's called the Erector Spinae group. Okay. You don't have to worry about the serratus posterior, inferior, but I do want you to know the Erector Spinae there, as well as the rhomboid minor and rhomboid major. Remember, minors are always above majors. This is C7 and T1 for minor, and then T2 down to T5, that's for major, for the spinous processes. And both of them attach to the vertebral border of the scapula. We get a close-up view. Again, we've done this. On the right-hand side, we have the upper trapezius, middle trapezius. I also showed you the lower trapezius. Then we had the levator scap, Splenius Capitis, and the Semispinalis Capitis, rhomboid minor, and your rhomboid major. There's your lats. We call it lats, but you'll need to write the full name, latissimus dorsi, and there it's cousin teres major, not to be confused with teres minor. That's teres major, but they both have the same insertion site. Teres major and latissimus dorsi both insert on the bicipital groove, also known as the intertubercular groove. Intertubercular groove. Muscles that move the scapula, nothing new. I think we've already done these. So upper trapezius, middle trapezius, lower trapezius, they're all going to act on the scapula. The upper trapezius elevates the scapula. Lower trapezius depresses the scapula. Middle fibers of the traps adduct or retract the scapula. Levator scapula will elevate the scapula. And then rhomboid minor and major, they adduct or retract the scapula, But because these fibers run upward in this direction, it pulls the inferior angle upward, which brings the glenoid cavity downward. So since the glenoid cavity is the reference point, we call it downward rotation. So the rhomboids adduct and downward rotate the scapula. They adduct or retract and downward rotate the scapula. From the side view, we can see serratus anterior. That's an important muscle. It goes from, gosh, the upper 8 ribs, goes around, and it goes underneath the scapula. It goes underneath the scapula and attaches like to the vertebral border here. It attaches to the vertebral border, but on the underneath surface of the scapula. Okay, and when this is weak, we see this in young children. Young kids, if you see them probably under the age of 10, sometimes 9 or 8, you see them at the beach and you look at their backs and you see their shoulder blades. We call it winging of the scapula, winging, where the scapula wings away from the thoracic rib cage. They call it winging of the scapula. Muscles that move the trunk. You don't have to know serratus posterior. Really, for the lower back, I want you to know the latissimus dorsi, which is a lower back muscle, but also a shoulder muscle. Splenius Capitis, yes. And semispinalis capitis, of course. So here's the Splenius Capitis. And then there's the semispinalis capitis. There's your levator scapula. There's the Erector Spinae, Erector Spinae group. Here's your Splenius Capitis, and there's your semispinalis capitis. Remember, capitis just means capital, or it means skull for up here. There's your semispinalis capitis again. Hopefully the repetition is helpful. Important muscle. When we look at the trunk, if we take the abdominal wall and we remove it and we look deep, right? Here's the spine. Here's like L5, L4, L3. Here's the pelvic, the iliac crest, right? Here's the iliac crest. Going from the last rib, so that's like the T12 rib, down to the iliac crest. It's called the QL, or the Quadratus Lumborum. Very important muscle, Quadratus Lumborum. It hikes up the hip. It can draw your hip upward. That's the QL, Quadratus Lumborum. It's between the last rib and the iliac crest. And then Psoas Major. Psoas Major is this muscle, whereas iliacus, I'll put an I, iliacus is this muscle. So the iliacus and Psoas Major come together and they join, they attach distally. Psoas Major attaches to your spine somewhere around here, like around T12. And then it goes down to the lesser tubercle. I'll do LT here for lesser, not tubercle, lesser trochanter of the femur. It's a hip flexor, like Stairmaster, like raising your hip up. That's Psoas Major. And again, this one here, let me do a different colored pen here. Let's do it black. So this one here on the right-hand side, that's the iliacus. This is the iliacus. And the iliacus, along with Psoas Major, we call it the ilio-psoas, because they both come down, they join their tendon, and they insert on the lesser trochanter of the femur. Together, those are your hip flexors. When your hip flexors are really tight, it gives someone the appearance, they call it like a bubble butt, where you get this hyperlordosis of the lower back and the butt sticks out a little bit more. That's because the lumbar lordosis is increased due to these tight hip flexors. So you'd want to elongate these and to stretch these out.